Hi, everybody who is jumping on. We're just giving everyone about 2 minutes before we start. So at 11:02, we will get started.
All right. Hi, everyone, and welcome to the Mental Health Services, an Unfulfilled Promise for consumers with mild to moderate mental health conditions. My name is Aviva Prager, Senior People and Systems Manager at CPEN. And before we get started, I'm going to go over some housekeeping and share some of the webinar features with all of you. So if you're new to Zoom webinar, welcome. And this slide has a diagram pointing out some of the features that we're going to be using. And first off, this webinar is being recorded and everyone is muted. Closed captions are available. To access those, click CC live transcript at the bottom of your screen and click show subtitle. And you can also click view transcript to see a transcript of the webinar. We also really encourage you to use the chat box to introduce yourselves and interact with each other. Feel free to hop in the chat now and share your name, your pronouns, your organization, your location, and CPEN staff will be monitoring the chat and adding any relevant resources throughout the webinar. So the chat button is the little speech bubble icon. And the CC live transcript has a little CC in a box and says live transcript. If you have questions throughout the webinar, please use the Q&A function to ask questions. CPEN staff will either respond to the question or mark the question to be answered live when we get to our Q&A portion. And if someone asks a question that you're also interested in knowing the answer to, you can use the upvote feature to give it a me too. And we'll do our best to answer as many of the questions as possible. And that Q&A icon, it says Q&A and has 2 speech bubbles as the icon. Finally, we'll also be using the poll feature. And we want to get a sense of what our audience is for the webinar. So our first poll question is, what type of organization do you work for? And please select the appropriate answer. So I'm going to go ahead, I'm going to start that poll and then we'll continue on. So I see folks putting it in. We'll give folks just 30 seconds or more to get answered. Thank you for putting in your poll answers. All right, great. Thank you all for participating in our poll. And now I'm going to turn it over to my colleague, Carolina Valle, CPEN's Policy Director, to give a brief history of CPEN and our work in mental health.
Morning, everybody. Carolina Valle here, Policy Director with CPEN. Before I introduce our main speakers, I wanted to give you just a brief overview of who CPEN is and the scope of the project you're about to hear about. So CPEN is a statewide health advocacy organization, and we're really focused on addressing racial and ethnic disparities in health, including mental health. We do this work through a number of different strategies: policy, community advocacy, data, and research. you'll see a little bit of our strategy work in this project. In terms of the history of our mental health work, back in 2016, we started working with diverse partners from across California to establish the Behavioral Health Equity Collaborative, which includes state and local organizations that represent diverse communities, including immigrants, refugees, youth, LGBTQ+, and people of color. And really the mission of BHEC is to bring consumer voices from communities of color to state policymaking tables, to specifically advocate for greater investment in appropriate and quality mental health services. This is because we know that while the state's coverage expansions are widely recognized, non-white and low-income English proficient consumers continue to struggle to access high quality, high value care that meets their behavioral health needs. So since 2016, we began engaging partners in mental health and have expanded our state and local policy advocacy, our data analysis, and our partner engagement work. We've worked with the California Department of Public Health Office of Health Equity to promote the use of culturally competent community-defined practices. We've also successfully pushed for the passage of AB 470 in 2017, which directed the California Department of Healthcare Services to begin collecting disaggregated data for Medi-Cal mental health. We're also appointed members of the California Health and Human Services Agency Behavioral Health Task Force and the Department of Healthcare Services Behavioral Health Stakeholder Advisory Committee. We've also published several reports that highlight our findings and recommendations relating to eliminating mental health disparities, including our most recent publication, Policy Options for Community-Defined Evidence Practices. Next slide. So now I want to share with you a little bit about this project that you'll be hearing about regarding challenges and opportunities to improve access for people of color and the Medi-Cal mild to moderate mental health benefit. Over the past couple of years at CPEN, our data and research team have been looking at and analyzing disparities in public mental health and found that first and foremost, access is improving. However, while there is overall improvement, disparities persist in communities of color. In particular, we found that there are significant disparities among communities of color and limited English proficient consumers. We at CPEN know that by failing to serve diverse patients well, the state's mental health system is failing a significant portion of its consumers. And so in order to improve quality and achieve better outcomes, the state needs to consider how it can enhance the delivery of care to its diverse consumers. And even as California faces these challenges, we know there are also significant opportunities to move forward and direct resources to address longstanding and emerging disparities in mental health. We look forward to working with all of you to improve access to care for our Medi-Cal consumers with mild to moderate mental health conditions. So looking at this slide, you'll see there are three components to this project. First, as I previously mentioned, we have a data analysis, which Jeffrey Coe, our Senior Grants and Project Manager, will be talking about. But we needed to capture the consumer perspective, and we also needed to capture the provider perspective. So CPEN reached out to two consumer groups who could really give us insight on some of the challenges and opportunities to improve access to care. So we did a very small sample of interviews with primary care providers to hear from them about their approach to treating patients with mild to moderate mental health conditions and their referral process. We also worked with our BHEC partners to do a community review of Medi-Cal managed care plan websites to hear from them what the accessibility concerns are, as well as their understanding of the materials. So just a couple technical notes. One is you'll hear us talk about mild to moderate mental health conditions quite a bit today. And really what that means is when we talk about mild conditions, we talk about conditions that are really limiting the effect on people's daily life. And when we talk about moderate conditions, we're talking about symptoms that can make their daily life much more difficult than usual. So changes in sleep, in appetite, in mood. These are some symptoms that we can see on the mild side as well as the moderate side. Some of the diagnoses that you're talking about include depression, anxiety, ADHD, and PTSD. And then lastly, when we're talking about the types of providers in mental health care, we're talking about psychiatrists and other providers who are licensed to write a psychiatric description and therapy counseling, with providers like LMFTs, LCSWs, PsyDs, and licensed counselors. So just wanted to give a couple of those technical notes because there might be some questions about the types of providers we're talking about and the definition of mild to moderate care. So now I'm going to pass it over to my colleague, Jeffrey, who's going to talk a little bit about our data findings.
Great, thank you, Carolina. Hello and good morning, everyone. My name is Jeffrey Koh, Senior Projects Manager at the California Pan-Ethnic Health Network, and I'll be presenting some data on current access disparities for consumers of mild to moderate mental health services. Next slide. So before we review the data, I want to quickly go over why we're so focused on mild to moderate mental health. The Federal Substance Abuse and Mental Health Services Administration estimates that about 14% of Californians have a mild to moderate mental health diagnosis. And that's nearly 1 in 7 Californians. And this estimate was actually generated before the COVID-19 pandemic, so it could actually be a significant underestimate of the actual prevalence today. What this data shows us is that there's really significant demand for these services. Next slide. The most comprehensive data we have on these services comes from AB 470, which is a CPEN-sponsored bill that was signed into law in 2017. AB 470 requires that the California Department of Healthcare Services tracks and reports on robust evaluation measures for Medi-Cal mental health services. The first iteration of this data set was released in 2019, and it provided detailed enrollment counts and utilization information for Medi-Cal enrollees served by county specialty mental health plans. This data was disaggregated by race, ethnicity, language, age, and gender. Subsequent revisions added information for mild to moderate mental health services. And finally, in 2021, data on individual managed care plans that served Medi-Cal consumers was also added. These data sets are available to the general public on the California Health and Human Services Open Data Portal. Next slide. So despite overall improvements, communities of color continue to have lower access rates. Although some groups now have significant levels of access close to the 14% estimate of need reported by SAMHSA, there are significant disparities by race, ethnicity, and Asian Pacific Islanders, who already had the lowest access rates, actually saw a decrease in access during fiscal year 2019-2020. Next slide. Moving on to look at the data by language, we see some really similar trends. When looking at the top 5 written languages reported by Medi-Cal consumers, access is significantly lower for enrollees who report a preferred written language other than English. These 5 languages account for 95% of all Medi-Cal consumers, and English alone accounts for 67% of all Medi-Cal consumers. Note that DHCS does not provide data on a consumer's preferred spoken language, nor does DHCS provide information on what language is used to conduct a mental health visit. Next slide. It's also important to evaluate how well patients are engaging with their treatment and if they're able to get regular follow-ups and continued treatment for their mental health conditions beyond the first visit. AB 470 provides a measure of engagement defined as 5 or more visits in one fiscal year to compare performance across groups. And here we see that for all groups, the engagement rates are much lower than the access rates, suggesting that many patients who seek and initially receive mental health care may not be getting continued treatment. And this could be because either they no longer need care, or more concerningly, because they're failing to get follow-up care. Next slide. Our takeaways from the data are as follows. Firstly, access is improving. Since the introduction of the mild to moderate benefit, more Medi-Cal consumers have been able to receive some sort of mental health care. Secondly, racial disparities are persistent. Despite these improvements, communities of color still have lower access rates to mild to moderate mental health services. And third, linguistic disparities are also persistent. Most consumers who have a written language other than English have significantly lower access rates. Together, these findings echo what we've been hearing from community members for a long time. that for many, mental health care is not there when folks need it, and that many are failing to get the care they need when they seek it. However, the data really provides only a high-level view of what's happening, and it doesn't tell us a whole lot about what individuals experience when they seek care and why they may not be able to get care. That concludes my review of mental health services for consumers with mild to moderate health conditions. So I'll turn it back to you, Susan.
And Jeffrey, I'm going to point out there was a quick question here in the Q&A about your slides. Are they depicting adults, youth, or both?
Yeah, that's a great question. So these slides are for the adult population. AB 470 does actually provide a separate data set that looks specifically at youth. That data is organized a little differently just because the mild to moderate versus the severe distinction is applied a little differently for youth. So we didn't combine them all together to make sure the data remains consistent.
Great. Susan, I think we're going to pass it off to you now.
Okay, great. Hi, everybody. My name is Susan Flores. I'm the Senior Policy Coordinator here at CPEN, and I conducted a majority of the primary care physician interviews and then also oversaw the community review of the managed care plans. And so I will be going over findings from those two experiences and also recommendations that came about from those experiences. So please, let's go to the next slide. So this first section is going to be about the interviews I did with the 10 PCPs. Again, Carolina mentioned this is a small pool. This is in no way really representative of all of the issues that consumers and PCPs are going through as it relates to mental health referrals for mild to moderate conditions. But I think it's a good peek at what consumers and providers alike are going through when trying to access care. So we chose 10 PCPs and we did a call out. 10 PCPs volunteered to be interviewed for an hour-long interview. All of the PCPs work at FQHCs, which you'll note, or you might know, that causes a little bit of an issue with the data in that a lot of FQHCs have in-house mental health staff. So referrals to independent providers through a managed care network are difficult to make because you would just normally refer to an in-house staff member versus actually reaching out to an independent provider. However, there are still findings to be made during these interviews, even with that in mind. And so some of the questions that we asked our PCPs are on the right-hand side here. So the first one was, are you aware the Medi-Cal program offers a comprehensive behavioral health benefit? On a scale of 1 to 5, how confident are you guiding patients to find an in-network behavioral health provider with their Medi-Cal managed care plan? And if there was someone else in the office who coordinates care, like finding a behavioral health provider for patients. So if we could go to the next slide. So top 4 findings, there's multiple findings in each of these sections. So I'm about to go through them. So under poor awareness of the mild to moderate benefit among providers and consumers. So 5 out of the 10 primary care physicians we interviewed were completely unaware of this benefit under the Medi-Cal program. This was a huge surprise for these 5 out of 10, since they normally relied on referring to the access telephone line or referring to county services. At no point did it cross the mind of these 5 PCPs that they could actually reach out to the patient's managed care plan and find a therapist or psychiatrist or whoever to help treat the needs of their patient. Of the remaining 5, 3 said while they were aware it was a benefit, they didn't know how to guide their patients in accessing or speaking on what the benefit covers, with actually one provider believing that there could be a copay involved. So kind of insinuating that there are fees within this program, even though the Medi-Cal program is, for the most part, free for most patients. Sorry, there was something in the chat. Somebody could deal with that. When the physicians were asked how confident they were in guiding patients to find an in-network behavioral health provider with their Medi-Cal managed care plan. 7 out of 10 said they were not at all confident. All the PCPs, however, I want to highlight here, are aware of mental health services available through the county for severe cases of mental illness, with one PCP saying that they've always been taught that Medi-Cal patients all have to go through the county for mental health care, and that it had never been mentioned that they go through their managed care plan. Under challenges finding available and in-network behavioral health providers, something that came up repeatedly in interviews was the use of Psychology Today, where in the experience of these PCPs, their patients come into the office and say, well, I actually tried to find a provider through Psychology Today, and I'm choosing a random plan here. I have Anthem and I chose Anthem on Psychology Today. I put my zip code in and I researched a provider and I clicked on it. And when I called them, they said they couldn't see me because they don't take Medi-Cal. And that's because Psychology Today doesn't sort their providers by Medi-Cal managed care plan, right? These are more based on private insurance, employer-based insurance, maybe even marketplace plans. They're not taking into account Medi-Cal eligibility unless it says Medicaid, in which case it gets a little confusing because they could be talking about the fee-for-service system versus managed care plans. So essentially, Psychology Today is not a reliable source for Medi-Cal patients trying to find a provider. Additionally, patients would go onto their managed care plan's website and try and look up provider directories there. That was difficult, however, and I'll actually show a visual of why this was difficult in the following slides. But essentially, there are way too many products on these managed care websites, at least the heavy hitter websites that have products in Medicare and in the marketplace and employer-based and Medi-Cal. There are way too many products to choose from that people would end up choosing the wrong product. And they would get a completely different provider directory that was not for Medi-Cal patients. So then they would call providers from that directory and the provider would say, I don't take your insurance, which can obviously be very confusing to patients because they're just like, it says on here you take Anthem, I have Anthem, why can't I be seen? And the sort of explanation of how managed care works becomes really confusing, really frustrating for consumers. And we have to keep in mind that these consumers are going through a lot, right? If they're seeking mental health services, it means they are already struggling. And so then to come across this like administrative bureaucratic barrier just makes it even harder to access care. The third point, challenges finding language concordant providers and ensuring quality language access. So 6 of the PCPs that we interviewed expressed a barrier that they come across when it comes to language capacity. While they do mention that they have phone interpreters that they can use during the appointment, that's usually a deterrent for patients. Like I've mentioned before, or just recently, mental health is a very stigmatized, a very sensitive topic for a lot of people. And confiding in your PCP for a lot of people is already very difficult. Having to add a third party, meaning a phone interpreter, just makes it even harder. And so apparently some of these PCPs in their experience when they've mentioned seeking counseling, but not having the language capacity to provide that counseling in the language the patient needs, the patients are sort of discouraged and decide not to move forward with counseling because it just seems too much. Additionally, what happens is that some patients who do end up going through with the phone interpretation actually come out of the experience not comprehending what the issues were and what the treatment plan is, because in some cases, the phone interpretation was too advanced for the patient's understanding. So there's sort of this mismatch of education level in how the interpretation is taking place. And so it's almost like the interpreter is speaking a whole other language and the patient just ends up even more confused without the care that they need. So that was an issue that the PCPs mentioned, at least according to language capacity, is that when there isn't language capacity, patients are less likely to move forward with care, at least mental health care. And then fighting providers with concordant experience. So this was brought up, and this is different from language concordancy or provider availability in that many Medi-Cal patients come with experiences that are very unique to that population. For example, a physician mentioned working in Sacramento and having patients that speak Dari, which is an Afghan dialect of Farsi. And this patient was needing mental health services. However, they could not find someone that this patient needed that understood their sort of specific cultural, sociopolitical, and generational concerns. And so this patient ended up, I believe, not receiving mental health care because it was so hard to find someone that could understand their experience as a person coming into this country as an immigrant, going through many sort of struggles and having traumatic experiences in their lives that a white mental health provider might not fully comprehend or be able to empathize with and be able to treat. And I bring up this example because, as we all know, Medi-Cal is going to be expanded to the 50 plus population of people who would not be eligible due to immigration status. This population has a lot of needs coming from countries with lots of issues, war-torn countries, issues with socioeconomics, political strife, you name it. And they also might speak other languages. So this is where sort of it becomes important, at least according to the PCPs, to hire providers that sort of reflect the needs of patients. And so these were our findings for the PCP interviews.
Susan, I'm taking a look in the Q&A and we've got a couple great questions. One, this is a comment, Lisa saying, it'd be really good for there to also be reporting on use data, given that suicide is 2% of the cause of death for that population. I want to uplift that comment. But the question for Jessica, or from Jessica, is what counties were these PCPs providing services in?
So these PCPs were spread out. Predominantly, though, the PCPs were in Sacramento County, Alameda County, and San Francisco. We had, I think, 2 PCPs in Southern California and Los Angeles, I believe. But for the most part, they were in Alameda, Sacramento, and San Francisco.
Great, thank you. And Lisa had a clarifying comment. Sorry, suicide is the #2 reason for death, not 2% of all deaths. I knew that. Unusual. Thanks, Lisa.
If we could go to the next slide. So some recommendations that came about from these interviews are the first one being integrating mental health referrals into the electronic medical record, the EMR, could lead to equity and parity. So a big issue that nearly all the physicians identified was that they're unable to immediately refer patients to a managed care plan mental health provider during an appointment, and that is a barrier. They mentioned being able to do that for specialty care, right? Like if a patient needed a referral to a cardiologist, or a patient needed a referral to another sort of specialist. I think another example that came about was like a dermatologist. These can be easily done through the electronic medical record, and the EMR, the electronic medical record, could incorporate several markers like gender, language, and therapy modalities. And the referral system would be integrated with the current referral system providers use, making it easier to refer quickly. However, this places the onus of maintaining an updated and accurate provider referral list on the corresponding managed care plans and not the patients. So like I mentioned before, an issue that some patients have had is inaccurate provider directories. With this integrated EMR system, those directories would have to be accurate. Otherwise, patients would be getting appointments for providers that cannot see them. The reason why the PCPs mentioned this integrated EMR system is because they feel currently mental health referrals aren't treated with the same urgency as specialty care referrals. So if they were integrated into the EMR system, there would be parity there among physical medical care and mental health care. And it would reduce the priority hierarchy found in healthcare. And like I mentioned before, this integrated system could incorporate behavioral health data metrics. For example, if this system were to be standardized across all Medi-Cal providers, data on mental health disparities across multiple factors like race, ethnicity, gender, sexual orientation, and gender identity and disability could be pulled at the clinic level and institutional level, making it easier to address disparities in mental health care, more specifically, the disparities that Jeffrey has just finished talking about in his section. The second recommendation, incorporating language and cultural competence in provider recruitment. I talked about the diverse needs of the Medi-Cal population. Physicians were aware of these diverse needs, and they said that managed care plans have to recruit mental health providers with increased language capacity and familiarity with cultural experiences that patients bring. A concerted and intentional effort to recruit providers with expanded language capacity and cultural competence is essential to meeting the needs of all Medi-Cal managed care members, is what we were told by one physician. And also another reminder about the Medi-Cal expansion is that the Medi-Cal program is going to start including more beneficiaries, which includes the undocumented population. And there's this imminent need, right? Like the need is now, now that we're expanding. This cannot wait. Finding providers with language and cultural competency is essential to meeting these new needs with this new population. On-call case managers and care coordinators. So, like I mentioned at the start, these PCPs work at FQHCs, and so they have people present in their facilities that often do a lot of case managing or care coordination, and they like that system, and so they recommended having a managed care plan staff available to coordinate appointment. And they understand that managed care plans have phone lines that patients and providers can call to get a list of in-network providers. However, they feel that patients need more than that. They need someone who will help make that first appointment and follow up if that first appointment is missed or if the visit was not a good fit. One of the complaints some of the complaints that the PCPs get from patients is that sometimes the mental health provider that they saw is just not a good fit. However, they don't want to go through the whole process of finding another provider, seeing as that was a big deal and a bit confusing. So they end up quitting mental health services after that experience. And so if they had somebody, a case manager or a care coordinator who would follow up after the first visit to make sure that the relationship worked, that would help in continuing mental health services. So essentially, these types of case management services are essential in ensuring beneficiaries receive the care they need without dropping off. And lastly, education and outreach campaign for beneficiaries and providers. Earlier I mentioned that half of the interviewed PCPs were completely unaware of this benefit. That's a pretty big chunk. I know it's a small sample size, but it's still pretty eye-opening that half of the PCPs were unaware. They suggested a campaign targeted to both beneficiaries and providers. Beneficiaries currently get a quarterly mailer from the Medi-Cal program in the mail. And the PCPs suggested incorporating mild to moderate mental health benefit education material into these quarterly mailers that would help patients understand their health coverage. And all of the PCPs stated they would welcome a training by the Medi-Cal program about how to complete a successful provider search and how to initiate a successful referral for mild to moderate mental health care. Additionally, providers would also like a bulletin that went directly to them rather than an office manager or a clinic director, because they know that they need to understand the benefit for themselves in order to make it easier to talk about with patients. And so I think the next slide is questions.
Yes. Got a little love here in the question box from Kenna. They're asking, pardon me, do you foresee the implementation of integrating primary care and behavioral health with the EMR system that you talked about affecting how patients with behavioral health diagnoses receive physical health care due to stigma? For example, a PCP not taking a patient's physical pain seriously because he or she has a diagnosis of schizophrenia, etc.
Yeah, so that was actually an issue that was brought up by PCPs, which was that this is really hard to do with like integrating the EMR with mental health information or mental health notes, because there's like a lot of regulations on HIPAA and making sure that people are unaware of these sorts of things for these reasons, right? Because of the stigma. I don't really have an answer for this. I think that is a serious concern with PCPs not taking a patient's physical pain seriously because of some sort of diagnosis. There has to be a way, however, to be able to integrate this system, as currently without integration, so many people are falling off and not receiving the care that they need. So I'm wondering if there is a way to hide specific diagnoses, however, still like raising the flag of a mental health condition. I don't know how that would work. That would be something that we'd have to talk about among providers, among advocates, among other stakeholders as to how integration actually looks like. All I know is that the PCP said that an integration has to happen. The design of that integration, however, wasn't discussed.
Jackie asked, do you have any suggestions on how legal service advocates can help improve access to mental health care on behalf of Medi-Cal beneficiaries?
Well, I think legal services advocates already do a pretty good job. I mean, the only thing is there are so many cases, and how many cases can legal services advocates actually take, right? So legal services advocates currently will receive calls to their offices, open cases, investigate cases, and advocate for patients by, submitting complaints on their behalf or doing some sort of care coordination. This is where I will say, Jackie, that I feel the responsibility of managed care plans comes into place. The fact that patients are calling legal services advocates and not their managed care plans to coordinate mental health care, it's kind of a question in my mind. Managed care plans are entrusted to provide some sort of care coordination and case management to Medi-Cal patients. And so I'm wondering why that's not happening. They have the same data that Jeffrey has or that we have on the utilization of the mild to moderate mental health benefit. So why aren't they working to try and fill that gap or like meet the needs of the patient population? Why is it falling on legal services advocates to improve access to mental health care when it's the charge of managed care plans to do that? Those are sort of the questions that I have.
Great. Those are, we got more. All right. Yeah, please drop your questions in the chat box. How are we doing on time? I just want to do a quick time check. Are we okay on time?
We have 20, maybe just this question, and then I'll have to move on.
Okay, great. So Nancy asked regarding language capacity, they were wondering if any providers brought up language capacity issues or thoughts for patients and parents / caregivers whose primary language may be different. For example, English speaking minor, but ESL parent.
I can't say that this did come up in the interviews, other than the phone interpretation services that are available and how using the phone interpretation services is a lot like telephone, like literally, in that so many things get lost in translation and so many times patients come out confused with the experience. I imagine that it would be even more confusing if you're talking to a parent, but the patient is a child. And then there's also the interpreter involved and then the physician. Like, I imagine that there could be a lot lost in that communication, which is why the need for expanded language capacity among providers is essential, to sort of get rid of that middleman, which is the phone line interpretation system.
Okay, Susan, I'm going to cheat and one more question from Uma. Move on. Is your sense that sampling a different set of 3 counties would result in the same type of responses?
Would result in the same type of responses? Well, I guess we'll refer to that more in the community review that we're going to talk about next, because we sampled 5 different counties for this. So, and I'll talk about it in that section. Sorry, not 5 different counties, 4 different counties. And we had similar responses. And this was a community review. So this is done by community partners and not by physicians.
Great. All right. Please feel free to use the chat and pass it back to you, Susan.
Okay, next slide, please. So this part is on the community review of Medi-Cal managed care plan websites to determine accessibility and understanding. So this is where we had some of our community partners in our behavioral health equity collaborative and also are having our SAY group test Medi-Cal managed care websites to see if they're user-friendly. So we created a scenario. It would have been like, you are a patient in Los Angeles County. You live at zip code 90011, I think it was. And you were told by your doctor that you would benefit from mental health counseling. You have HealthNet, and you would prefer to find a provider that speaks Spanish. Go and search. And so these are the findings of those scenarios. The counties that were tested were Los Angeles, Fresno, San Francisco, and San Joaquin. So these are our findings. Some of the questions for the community review. How did you know the website you were looking at was the correct website to find an in-network behavioral health provider? Was it immediately apparent you were looking at the accurate page and not a page for another one of the managed care plans products? So this again was what I was mentioning earlier, which is that health plans can have products for Medicare or for Covered California or for employer-based insurance. And the third question, were you familiar with the terminology used on the website? There were more questions, but these are just kind of like the top questions that I wanted to highlight. Next slide, please. So 3 points for findings, multiple points under those findings, and the community groups that tested these sites are on the right-hand side. So API Equality LA, Central Valley Immigrant Integration Collaborative, Little Manila Rising, Street Level Health Project, and Richmond Area Multi-Services, Inc. So the first point, long and difficult searches requiring multiple clicks. So on average, the tester spent 45 minutes looking for a provider on the managed care websites. And again, this included 1 qualifier, which was language. In navigating these sites, the testers reported between 4 and 8 mouse clicks to reach a mental health provider search site. Testers with 5 or more clicks reported being taken to external web pages that differed from the initial managed care plan site they started on. These external pages were often delegate plan provider search websites, so MHN, for example. These testers did not come across a web page explaining why they were being taken to an external site. Additionally, some providers, once they landed on the mental health site, were asked to input a quote specialty provider. And so some of the terms that testers used were therapist or were mental health or behavioral health. But one tester was actually uncertain of the correct term to use, so they left the search bar blank, which ended up leading to a list of hundreds of PCPs, not mental health providers. These searches also included terms that the testers felt their community members would not be able to understand. For example, one of the testers' search results had several licensed clinical social workers listed in their results. However, the tester felt that people in the community would misunderstand what a licensed clinical social worker was, since the term social worker is often synonymous with the term eligibility worker, which is a type of worker that Medi-Cal beneficiaries have interactions with through the Department of Public Social Services. And also when that term is translated to Spanish, so trabajadora social, again, that alludes to the sort of eligibility worker type of person and not a mental health counselor. So the use of that term in the list, they felt would have been confusing to their community members. Second point, confusion over the appropriate product to choose from. So if we could go to the next slide, please. The next slide after that. So if you go on here, we're going to go through the whole way to find a provider through HealthNet. So I'm showing you the whole website here. There is nothing on here that says Medi-Cal, even though HealthNet is a California-based provider, insurance company. So we're going through the search here. I'm going to put in the city and I'm going to put Los Angeles. And we're on the second tab, if you'll note. And this is what I mean by product. So these are all the products that HealthNet has. It's a drop down and people have to choose Medi-Cal out of this drop down, which is right there under state health plan. That's the part that gets confusing to a lot of people, including our testers, is what product do I choose when there are so many other terms in there that are also familiar. Like people are familiar with HMO, but they don't really understand what HMO means. People are familiar with the term Medicaid, but they could sometimes confuse it with Medicare. So they might choose the Medicare option versus the Medicaid option because they confuse the two. And so that was an issue that was brought up in the testing, was all of the products that are featured on websites. Aviva, if we could go back to that slide I was on. One more. There you go. And the third point was limited language access on the managed care sites and in the provider listings. So let's go to another slide. So can you move forward? One more. One more. There you go. So an issue that the testers had was that on the websites, there was no notice of language assistance, which is something that managed care plans have to provide to their beneficiaries that don't speak English. And if you, can we actually go two slides back? Okay, there you go. So this one's gonna not start apparently. So thank you. If you go on Anthem, you'll see on the top right-hand side, it says Español. That is the only option that members have in Anthem. to get language services. So if you speak Spanish, you'll get the help. If you don't, I don't know where else you would press to try and get help in your language. So these are sort of the issues that testers came across, which is that a lot of their community members speak a language other than English, and they would need that assistance. So if we go 2 slides forward again. So the Medi-Cal Dental webpage has a banner. So if you go on the left-hand side, there's a black banner, and underneath that black banner, there's several languages on there. When you click on those languages, it takes you to this web page on the right-hand side, which has a list of phone numbers that people can call to receive the language assistance that they need. And you'll see that there's headings for the languages that they offer, where people can call phone lines. This is sort of the bare minimum that we're asking plans to implement in their websites, which is a banner that leads to an phone line interpretation list that patients can call. But ideally, can you go to the 3rd slide or the next slide? Ideally, the whole website would be translated. And actually, this is something that's already been done on the Medi-Cal Dental side. Their sort of outreach and education site called Smile California does this already. So if you see on the right-hand side, it asks you to choose a language, and depending on which one you choose, the whole page will be translated. So in this example, I chose Spanish. So the whole page is translated into Spanish, and you could click on these things, and everything that you click on is translated into the language that you've chosen. So these are sort of the issues that people were talking about. And obviously, all of this falls under streamlining. So if we were to streamline all of these issues, like finding a provider, reducing it from 45 minutes, hopefully to 5 minutes, maybe even less than that, reducing the amount of products that people see on the websites, adding language assistance notices on the sites, and using vocabulary or language that is also accessible at a certain grade level is another important feature. So not using terms like Medicaid and Medicare, and if you are going to use those terms, clearly defining what those terms mean, because people don't know the distinction between these. Making sure that the term Medi-Cal is explicitly stated on these sites, that consumers aren't forced to learn that Medi-Cal and Medicaid are the same thing, just that our version here in California is called Medi-Cal. So that's the sort of streamlining that we're talking about. We could go to the next slide, which I think is questions.
So we've got some great questions here in the chat box, and we've got about 7 minutes left, depending on what it says. So questions here. So Erica wanted to know which Medi-Cal managed care plan websites were reviewed, and could you clarify if the community groups were employees at the orgs? It's a 2-parter.
So the community groups were employees at the orgs that were mentioned a couple slides ago. And some of them do direct service, so that's why we had them test, because they are so close to consumers. The managed care websites reviewed were HealthNet, Anthem, the San Joaquin Managed Care Plan, the health plan in Alameda, I'm already forgetting its name. I think it's like Alameda Alliance or something like that. And I think that's it.
We've got some other great comments in here. We'll give it another minute if there's additional questions. And yeah, I'm just waiting here for any other questions.
Let's move on to the next section, actually.
Great.
So this is a poll question. Do you attend any of the following meetings? So let's give this a start. The first one was, I don't attend any of these meetings. That's pretty funny. Okay, we can stop the poll. So majority of you do not attend any of these meetings. Okay, so let's get started. Next slide. So this is where I want to talk about opportunities for advocacy. So after this project, we realized that we need this sort of advisory group of committed advocates that are dedicated to addressing the concerns that we're talking about in this webinar. Ideally meeting on an ad hoc basis to discuss the pertinent issues in mild to moderate mental health care, and then also convening during one of our quarterly all network calls where we talk about all issues related to mental health, not just in Medi-Cal, but also in the county. And with plans to interact with state departments and managed care plans where we introduce this research project's findings and recommendations. The groups that I listed in the poll are the groups where we can present these sorts of findings and recommendations and kind of get the ball rolling on making these improvements. Like I mentioned before, the urgency is there, the need is now, and it's only getting worse, especially as we expand Medi-Cal to other populations. The growing need, and as we've seen throughout the pandemic, is also there. So this is why we are sort of listing this as an opportunity for advocacy, which is organizing to present these sorts of issues to these departments and asking them to make the improvements based off of the recommendations that we have gathered from the PCPs and from the community groups. Next question, next slide. Oh, it's another poll question. So would you be interested in joining a group of advocates in addressing these issues?
And Susan, we'll be able to snag, or Susan Aviva, we'll be able to snag the specific respondents to this question, right?
Aviva says yes.
Okay, great, thanks.
Okay, so just a couple more seconds. We can close the poll now, Aviva. So a majority of you said yes, that's very exciting. Next slide, please. Rukaya, if you can drop in the Survey Monkey in here, thank you. So if you would like to join this advisory group, please fill out the Survey Monkey. I also want to say, I didn't say this at the beginning, but this is going to be published in a report, everything that I've mentioned, plus more information that I just couldn't get to in this hour-long webinar. It's all going to be published in a report. The report is not ready, but it'll be published soon. Everybody that's registered for this webinar will receive it. So even if you know somebody that registered and didn't attend, they'll receive it as well. And then I'm certain that we're going to be making it available on our website. So you would be able to access it there too. If you have any remaining questions, please reach out to Carolina, my colleague. She's the one that's been doing the Q&A. I see we have 1 minute, so I would be able to take on questions at this point if there are any remaining.
Last question, well, we got a couple more here. Patrick asks, so is the absence of use-focused strategic time resources resources constraint or something else? So is the absence of a use focus due to strategic time issues or resource constraints or something else?
Yes, that's right, Patrick. Time, resources, capacity constraint. Ideally, we would love to disaggregate this kind of research in a lot of ways that just goes beyond youth, right? So it would be youth, seniors, disability, race, ethnicity, language, all of these things. However, I was predominantly the only person working on this project. Some of my colleagues helped me from here or there, but it's a pretty big thing to take on. And this is essentially why we need the advisory group to sort of pull all the capacity of everyone and everyone's experience. And it sounds like you have a lot of knowledge and experience yourself. And so I hope that you join our advisory group so you can bring to the forefront this issue on youth, and we can put a focus on it.
Great. Well, I think that's about it. Susan is actually outgoing from CPEN. She's going to be returning to law school. So, please feel free to reach out to any CPEN staff, myself included. And I don't know, Susan, if there's any final words that you wanted to share.
No, I just really hope you all sign up for the advisory group. I am looking forward to hearing about all the amazing things that this group will be able to accomplish and hopefully address all of the issues that the PCPs and community groups mentioned. And we could start seeing changes on how people are accessing mental health care.
Great, awesome. Well, thank you all so much for joining. And we will be sending out a recording of this webinar. And you'll also be getting the final report published in August. So thank you. Take care.